Hi everyone, this is John Mandrola from the Heart.org on Medscape, and I'm here at the 2016 CardioStim meeting, which is a European Heart Rhythm Association meeting. I'm with Dr. Charles Love from New York University, Langone Medical Center, professor of medicine, and Chuck is a friend of mine, and I'm pleased to have him, and we're going to talk about a lot of different topics in pacing and defibrillation today. Welcome, Chuck.
Thanks, John. Great to be here with you.
Now, you were here presenting an abstract on a new extraction technique.
Yes, there's a new tool that's been out now a little over a year, almost 2 years now, called the TightRail. It's a mechanical lead extraction device that we use to remove the fibrous adhesions that grow around a lead, holding it into place in the body, so that if you have a situation where you have to remove a lead from a malfunction or infection or whatever, we can hopefully remove these safely without damaging the vasculature or the myocardium.
And the results were positive.
Yeah, they're very positive. It's another tool in our toolbox. I think this is a really important concept for people to understand, that there's no one tool, the laser, the TightRail, the evolution. We have a lot of different tools out there, and people say, well, which one's the best one? It's like you wouldn't go to a car with one wrench or one screwdriver. You need both. You need a whole set of tools to be successful in repairing a car. It's the same thing with lead extraction. You need a set of tools and know how to use these tools properly in the right patients to be successful and safe.
So that was a lead-in to my next question, which is you do a ton of extractions, and has extraction really changed that much for you as an expert in the last, say, few years?
Well, the basic precepts in terms of how we extract the lead hasn't changed that much, but the tools have expanded, and we not only have new tools for removing devices like this TightRail and this Evolution RL, which goes kind of allows you to kind of bore these leads out going left and right, but also a very exciting item has just come along in the last several weeks, essentially, and that is this balloon to occlude the vena cava should we get a tear in the vena cava. One of the most devastating complications we have in lead extraction is a tear in the vena cava, and a patient can exsanguinate into their right chest. The idea behind this balloon is that we leave a guide wire up in the vena cava, and if we do get a tear, we can advance this balloon up quickly. It's a large balloon, very compliant, so it's squishy, and we can blow this up to essentially put your finger in the dike to seal off the hemorrhage until a cardiac surgeon can go in and close it off. We've had excellent results in animal trials, and it's now FDA approved, and we have it available to us on all cases.
Nice. So that's like a bridge.
In fact, that is the name of the device. It's called the bridge balloon. It was a lob. That was great.
So what is the most common indication that you do extractions for now?
Well, I would say the most common indication is probably still lead failure in my world, but the most important indication is probably going to be infection. Infection is an extremely important reason for taking out leads, and we all learn in medical school in our surgical rotations, if there's a foreign body in an infected area, get the foreign body out. And the infection will usually clear up even on its own in many cases. But if we have a pocket infection, we see people trying to salvage the pocket, moving device to a different plane, lots of antibiotics, and this is a setup for failure. They almost always fail. Not only that, but then you can take a local infection and it can become a systemic infection, and you have a very, very sick patient then. So endocarditis, absolutely class 1 indication for taking a lead out. Pocket infection, and not just a little cellulitis post-operatively, but truly a pocket infection, class 1 indication. Get that device out. The longer you wait, the higher the morbidity and mortality occurs. It's a significant issue, and we see so many people late into the therapy after weeks of antibiotics, and it just doesn't work. You got to get these out.
Yeah, so patients are getting older. We're doing more gen changes, and so the gen change has 10-year-old leads in it, and then if they get an infection after that, it's a real problem. Absolutely.
Not only is that a problem, but you bring up a great point in terms of these older pockets and gen changes. Gen changes, the simple gen change, what do we start our fellows off when we're training them in EP for devices? The first thing is the simple gen change. It's the most complicated, it is associated with the highest degree of complication of anything we do in terms of infection, 2 to 4% by most decent studies that are out there. And if you get an infection, all of a sudden you take a patient who is quite stable, you expose them to endocarditis and to the risk of lead extraction on top of that, which isn't so great. People have this perception that the risk of complication is around 5% for a lead extraction, and death rates are 1 or 2%. It's actually quite a bit lower than that. The major adverse event rate for a lead extraction is around 1.5% or so, and the death rate is around 0.3% at high quality institutions.
Yeah, so I was going to push you on that a little bit. It really does. I was going to ask you, has the increase in supply of extractors or extraction centers been a really good thing? And it kind of gets to that whole experience.
Yeah, experience is such a big issue, not only in lead extraction, but any other procedure we do. Nobody would go and have an angioplasty or a stent placed in their coronary by somebody that does one a month or one every 2 months. And yet we have people going for these very complex procedures, which in good hands have excellent outcomes and excellent safety profiles, but they will go to people that kind of say, oh yeah, I can do that, and they buy the tools, or they have seen a few done, or they have minimal experience. And most of the time it works out well, but clearly experience leads to better complete extraction rates and lower complication rates.